So we look forward to our very eminent moderator and speaker, Dr. Rajesh, who's going to give us tips for graft preparation. And I would want Dr. Bhaskar Srinivasan to come up with questions for him. On to you, Dr. Rajesh.
Yeah, my slides are visible.
You started? Yes.
At the outset, I would like to thank Dr. Chitra for involving me with this ARC session. My topic is donor preparation in DMAC, no financial interests. Now, Decimus membrane endothelial keratoplasty is the preferred technique of replacement of the dysfunctional endothelium. Here, the donor Decimus membrane is harvested and injected into the host anterior chamber, where it is unfolded using a no-touch surface tapping technique. And once the stained Decimus membrane scroll is unfolded, you use an air or a gas bubble to secure it in place. And this has given faster visual recovery with a greater percentage of patients achieving 20/20 or better, and it has the least risk of endothelial rejection. Now, this is a paper published back in 2019 where they did a survey among people who had completed a formal training for DMAC. When they went back a year later, majority of them were still not doing DMAC, and in the survey they indicated that almost 50% of them indicated that it's the anxiety related to tissue preparation because of which they have not been able to start with the DMAC surgery. If you have a DMAC preparation failure, you have a loss of donor tissue, which can lead to cancellation of surgery. You have to get another tissue from the eye bank, so you have to, again, additional cost. And this makes the learning curve for DMAC steeper. And depending on the experience of the surgeon, the loss rates may vary between 2 to 20%. In the Western country, especially in US and Europe, you have the eye banks doing this job for you. They may give you either a pre-strip donor where the Decimus has been peeled off 80% from the stroma, and then all the surgeon has to do is to punch out the desired size and complete the peeling. Or they go a step further, they even prepare the ideal size DMAC scroll, stamp it, stain it, load it into an injector. So it's called the patient-ready DMAC donor. But all this comes with an additional cost. The average cost of a pre-stripped DMAC donor or a patient-ready DMAC donor varies between $2,500 to $3,000. Here in our part of the world, the donor tissue has to be prepared by the DMAC surgeon. You can do it pre-operatively 24 to 48 hours earlier, or you can do it even during the surgery. The ideal donor age recommended for somebody starting out with DMAC is between 60 to 75 years. The cell counts 2,500 or more. You definitely would like to put a S or an F stamp on the stromal side to help recognize the orientation. And the trypan blue staining is done for 1 to 2 minutes duration. And this paper published in 2013 found that you can, in 98% of the eyes, you can fairly prepare the DMAC graft in a reproducible manner. And the younger age group, the tissue tends to scroll more, it is more elastic. And if you go older than 75 years, the scrolling is less and the tissue also becomes a little bit more brittle. The donor preparation, this was the earliest reference from Frank Price and Arthur Giebel, where they described the scuba technique or the submerged cornea using background survey. So they would do a peripheral break in the Decimus using a blunt-tipped instrument, following which the tissue is immersed in the donor storage solution. So the surface tension is minimized, which allows easy handling of the Decimus membrane as it's being peeled off. And also, as it is floating in the fluid, the reflections from the background go away, allowing better visibility. And once you have done the partial peel, you would prepare the graft as what we'll show subsequently. The other major advancements was from Peter Wellman from Mark Terry's group, where they showed that you can use a 2 millimeter or 3 millimeter punch to create a stromal window and then access the Decimus membrane from the stromal side to put in a S stamp, which again helps in identifying the correct orientation intraoperatively. So you do a partial trephination, 9.5 to 10 millimeter, then you do an edge lift, after which you do a partial peel of the Decimus membrane, about 50 to 60%, and then keep it folded, go ahead, do a stromal punch using a dermal punch measuring 2 to 3 millimeter in diameter. Then you can float the Decimates back into position. Now flip over the donor tissue, access it from the epithelial side, open up the stromal window, put in your S-stamp, and then you can come back and you can put in your 8 millimeter punch or 8.5, whatever you want, and then you can peel off the donor and then stain it with trypan blue for your surgery. This we published back in 2015. Now here, looking at the two different techniques, the peripheral break can be done using a Trifine, which is a 10 millimeter, 100 micron depth blade, or you can use any pointed instrument to create this peripheral scraping, whereby you only break the Decimates membrane and you don't break the stroma. The disadvantage is that if you create that peripheral punch a little deeper, then in younger donors, especially, you're getting that peripheral edge to become free or to identify the Decimates membrane at the periphery can be very challenging. So that's advantageous when you just do a peripheral scrape. The disadvantage of the peripheral scrape is that it can create irregular edges for which you have to go and remove those peripheral tags. Otherwise, they would lead to formation of radial tears. So you do a partial peel, about 60 to 70%. It's important when you are doing this peeling process that the entire Decimates which is separating separates in a straight line and you don't see any stress lines, because those are areas of abnormal adhesions where you can get a horseshoe tear. Or if the periphery is not free, you can have creation of radial tears which can extend centrally. So once you have done that, you make the stromal punch, float the Decimates back into position, flip over the donor tissue, and you can see here that we are drying the edges and then flipping over, making the F-stamp, and then you can do your desired 8 millimeter. 8 millimeter is the common diameter that we use for most of our surgeries. And then you can complete the peeling, what you see here. That's almost 80%, which is already partially peeled. And then you complete the peeling process and you can stain it and use it for your surgery. So that's what I was trying to indicate, that if you use a peripheral punch, you get a nice circular cut. But if your depth of the cut is little more, sometimes identifying the free edge of the Decimates is difficult. When you do a peripheral scrape, you break only the Decimates. There is no break in the stroma, but you can have irregular edges. So you have to first go ahead, remove those tags so that you don't get a radial tear when you're doing the peeling of the Decimates. This is a nice paper from Mark Gorovoy, where they looked at the donor tissue characteristics. On an average, the peel time was about 10 to 11 minutes. And they found that only in about 6% cases, they got the tears, out of which 3, they could, almost 50% of them, they could manage to use for surgery, despite having the peripheral tear or non-central buttonholes. So almost 97% of the tissues were used. They found that tissues which were older than 65 years had slightly faster peel time. And if you did have a complication in one donor eye, the pair would also have the same problems while peeling. So it's important that if you have received a pair of donor tissues from the eye bank and you have complications in one, don't go ahead and try to peel the Decimates in the second one, because you're likely to have the same problem. So what I do is, if I have a problem with the peeling of donor on one eye in my surgery, I definitely inform the eye bank about that, so that if they have given the pair of the tissue to somebody else, they can indicate that this was a problem that happened with the first donor. The other problem is that when you are doing this regular peel against a white background, the edge is not seen very clearly. Then that can result in delayed identification of the tears. So this is something that we devised 2 years back. This is an illuminated chamber, which is a battery-operated illuminated base onto which a transparent endothelial punch block is placed. And here you see that it provides a retroillumination. So now here, when you peel the Decimates, just like you see your capsular axis, here you can see the Decimates pretty well. And this way, if you do encounter any radial tear or a central horseshoe tear, that can be picked up much easily. And it makes it easier for you to, overcome the learning curve for preparing the donor tissue as well. So you can see the difference in the contrast of the edge that is getting peeled off standard versus using the retroillumination device. There are other techniques of injecting fluid or a liquid bubble technique, where you inject trypan blue dye in the peripheral stroma to create a type 2 bubble. Not very reproducible in my hands. You can do a pneumodissection, which I think Susan is going to talk about. You can do manual dissection of the decimus membrane using dissectors, which Donald Tan likes to do with his micro dissector. And Dr. Mourin from France has also described where he mounts the donor tissue with the endothelial surface facing up on an artificial chamber. And then he tries to dissect the decimus membrane using a hydrodissection cannula. Recently, Zamali's punch has been described from Italy, where it's like a yogurt peel technique. This again, it works, but not necessarily in all kind of donor corneas. So this is in short about the donor preparation in DMAC, and thank you for a patient hearing.
That was a wonderful presentation, Dr. Rajesh. Dr. Bhaskar Srinivasan, on to you. One question, we'll have to go on to the next speaker after that.
A lovely talk, Dr. Rajesh. Just wanted to know, in case you end up having a tear of the donor while preparing, how would you go about using the same tissue, or you use a spare tissue?
So we have used donor tissue even with 30 to 40% of the tissue being lost. So you can still go ahead and use it like a hemi-DMAC. The only problem is that there will be, if you have already stripped the decimus membrane from the host, the bare area of the stroma, there will be some persistent edema which you'll have to manage. Over a period of time, that edema will resolve. You will have a slightly lower cell counts, but it is something that can be managed. So you don't really need to discard the donor tissue, even if you have peripheral tears. The only thing is early recognition. Sometimes if you feel from the periphery that the dissection is not happening as you plan, you can either, instead of proceeding with that, if you have another tissue, you can move on to using another donor tissue, or you can convert it to a DSEC. So you can mount the tissue on an artificial chamber, then prepare like a DSEC graft, and you can use the same tissue for a DSEC without creating more problems.
Thank you very much, Dr.